The study that I'm presenting today was conducted at the Tata Memorial Center in Mumbai, India, and deals with perioperative critical incidents in patients undergoing major oncosurgery. So we know that anesthesia for oncosurgery is complex and associated with critical perioperative events. We wanted to prospectively examine the incidence of 8 chosen events and look at the association between these events and certain patient and surgical factors. These were the events that we chose: cardiac arrhythmia, severe hypotension, unanticipated, difficult or failed intubation, re-intubation, mechanical ventilation, perioperative death, anaphylaxis, and perioperative cardiac arrest. This was a prospective single-center observational study. We had approval from the Institutional Review Board. We included all major elective and emergency cases over a 3-month period, with data extracted from operating room records, anesthesia charts, and electronic medical records. So between 1st October and 31st December 2023, we had 1,887 cases. About 10% of these were emergency cases. Our patients were in the range of 2 months to 94 years with a mean age of 46 years, with most patients being in the age group of 20 to 60 years. Head and neck and breast cancer surgeries were the most common, accounting for almost 50% of cases. We had an equal distribution of men and women. Most of our patients were in ASA grade 2, with a few in other grades. Most of our patients, almost 2/3, underwent supra-major surgeries. So out of these patients, 168, that is 9%, had a major event, with the total number of events being 228, because some patients had more than one event. Post-operative mechanical ventilation, which is 6%, and vasopressor requirement, which was 4.5%, were the most common events. Emergency surgeries had almost twice the risk of elective surgeries, 15% versus 8%. When we looked at age, increasing age had a higher risk of having an event, with patients in the age group of more than 80 having almost 30% risk of having a major event. ASA status was also associated with increasing risk of an event. So patients in ASA 3E had a 30% risk of events, and patients in ASA 4E had almost a 60% risk of a major event. Increasing complexity of surgery was also associated with major events. So major cases had about a 5% risk of an event, whereas supra-major surgeries had almost 12% risk of events. These findings are logical and consistent with other studies, and they may be useful for risk counseling and resource allocation. Thank you.